Good afternoon, everyone. Today I am going to present a case on traumatic angle recession, glaucoma. There is no financial interest. A 12-year-old male patient came to IOPD with complaint of diminution of vision in his left eye for 6 months, intermittent pain, history of trauma by cricket ball 6 months ago. Patient was apparently well 6 months ago. He developed the pain and diminution of vision in his left eye after trauma by cricket ball. Then he consulted a local ophthalmologist where he was treated with some anti-glaucoma medication and antibiotic. He reported to our OPD for diminution of vision and occasional pain. He was on anti-glaucoma drugs like bimatoprost, timolol, dorzolamide since 6 months. There is no relevant family history. General examination is normal. Ocular examination, in his left eye, best corrected vision are 6/24 partial. Lid adnexa, conjunctiva and cornea is within normal limit. AC is quiet and formed. Traumatic mydriasis is present in his left eye. Non-cataractal lens was present. Intraocular pressure was done by Goldman applanation tonometer at 10:30 am in his right eye 16 and left eye was 19 mm of Hg on day 0. Day 7, there was intraocular pressure is 14 and 17 mm of Hg. Gonioscopy was done by 2-mirror gonio lens in his left eye, widening of the ciliary body, angle recession more than 270 degree present. Right eye gonioscopy was normal. Perimetry was advised, but patient did not show up. This is the fundus examination was done by 90 diopter or indirect ophthalmoscopy. In his right eye, fundus examination is within normal limit. Left eye, there is disc pallor is present. Cup and disc ratio is 0.9:1 and NRR thinning is present. This is the OCT, disc and macula of left eye. On the basis of above finding, left eye traumatic angle recession glaucoma was made. Did include glaucoma due to hyphema, inflammatory glaucoma, unilateral steroid use, secondary glaucoma following the intraocular surgery. This case was managed by medical treatment, topical anti-glaucoma drugs like bimatoprost, timolol, dorzolamide. Left eye trap with MMC was planned, but patient refused surgery. Lifetime follow-up was advised. Angle recession glaucoma is a secondary open angle glaucoma due to blunt trauma, which causes the tear in ciliary muscles. Angle recession is an indicator of the previous trauma resulting in chronic IOP elevation. It has been seen that 270 degree recession, there is a risk of glaucoma is 5%. 360 degree recession, risk of glaucoma is 24%. Ocular trauma with hyphema, there is a 71 to 100% develop the angle recession and 1 to 20% recession develop into glaucoma. Development of glaucoma in the fellow eye is seen in 50% of cases, whereas the angle recession develop into glaucomatous optic neuropathy. Pathogenesis include the blunt trauma which forces the aqueous humor laterally and posteriorly against the iris and the angle. This exerts the traction on the root, leading to the tear between the longitudinal and circular muscles of ciliary body. Two other mechanisms proposed to explain the elevated IOPR: loss of tension of ciliary muscle on the scleral spur, which narrow the Slem's canal. Hyaline membrane across the trabecular meshwork may be another mechanism to explain the decreased aqueous outflow. Management of the angle recession include medical management, topical anti-glaucoma medication like alpha agonist, beta blocker, carbonic anhydrase inhibitor. Organ laser trabeculoplasty was unsatisfactory results and failed to lower the IOP in a long term. SLT is ineffective. Trap with MMC is successful in lowering IOP but increased risk of failure. GDD has some benefits, is seen in traumatic angle recession. This include the present case turned out to be a traumatic angle recession. Such cases should be monitored in an aggressive way. Lifelong follow-up is mandatory and advised. Thank you.
Dr. Shania, so do you know any reason why in such cases the other eye should also be examined right from?
Because in some patients there is a widening of ciliary body is present.
No, the other eye. See, a patient who has developed a angle recession glaucoma because of blunt trauma has a higher predisposition to develop POH in the other eye. So that is why you should see the other eye also. Any other questions from the panel or the house?
What was the age of the patient? Sorry, I missed it.
Patient 14 years now.
14 years. Presented after 6 months.
6 months.
Trauma.
He consulted local
At that time, the
ophthalmologist.
patient was not on any medication.
He was on anti-glaucoma medications. Yes, sir.
I request Dr. Subhash.
Okay, thank you.
प्रॉब्लम कुछ नहीं सर, चल रहा था सही, पता नहीं क्या हो गया इसको।
And please note the time allotted is only 4 minutes. So please stick to the time.
नहीं सर, सुभाष। So 18 years poorly compliant male came to me with the complaint of decrease in vision for last 1 month, and he gave history of blunt trauma with cricket ball 2 months back, followed by a decrease in vision which resolved in 1 week time, and it was all because of hypema as per the previous record, and which improved with medical management. And when he came to me, his vision was actually finger count 1 feet with intraocular pressure of 6 millimeter only. Cornea was showing mild decimate fold, and anterior chamber depth was within normal limit. There was cortical cataract along with क्या हुआ? हम तो कुछ हाँ इतना ज़्यादा खुला हुआ सबको बंद कर दिया करो। अरे यार सॉरी सर, बस वेरी सॉरी। कैसे कर रहे हो मैनेज? नहीं लैपटॉप का प्रॉब्लम है तो देखना था ना, ये तो पहले चला इसमें सही चला। नहीं ये तो आप लोग का ऑडियो विजुअल ठीक नहीं है, तो हम लोग एलओसी का होने के नाते तो बताएंगे कि आप लोग का सुना। अभी क्या कर रहे हैं, आप क्या करने वाले हैं? लेट दिस रन ओवर, ठीक है। हाँ, posterior segment was not very much adequately visualized, but the indirect ophthalmoscope did show some disc hyperemia with blurred disc margin, and it looked like retina was attached. But to confirm whether there was retinal detachment or not, we did the ultrasound, and there was elevation of the disc because of the disc edema, and there was choroidal detachment, thickening of the ciliochoroidal layer without any retinal attachment. But what was most important was the gonioscopy, and it showed there was posterior and peripheral anterior synechia inferiorly with CD cleft from 5 to 8 o'clock position, and the visualization was little difficult. This is the video of that same gonioscopy. See, this was, yeah. You can see the decimate fold there, and it was difficult to do the gonioscopy, but somehow the CD cleft was visible. I could manage to do the gonioscopy with the JAS 4 mirror. You can see very well the CD cleft. See here. So what next? Just to confirm, we can do UBM or we can do the anterior segment OCT. UBM was not available at that point of time, so we did the anterior segment OCT. You can very well see here the fluid in another view. What are the treatment options for me? It was to reduce the anti-inflammatory which was there, just to induce the inflammation, or do the direct closure. So I stopped the steroid, started on cycloplegic, and when it did not improve, I did the photocoagulation, and with the last one which I did was the putting CTR in the sulcus with cataract surgery. So this was the sequence of event which I took upon just to control that, but patient did not improve with the topical medications or stopping the steroid. So the patient reported after 2 weeks, still there was no improvement and cataract had increased. So I thought of doing the photocoagulation, and you can see the photocoagulation mark here. 2 weeks later, again the status was not very much improving. So what I decided that I advised the patient to undergo cataract surgery along with the CTR implantation in the sulcus, and if not, then to go for the cyclopexy. So after the surgery, the vision improved in 3 days time itself, and the IOP started rising, and I could see there was some mild disc edema with macular fold, and 2 weeks time vision improved to 6/9. You can see the disc picture here, and subsequently the SOCT also showing improvement in 2 weeks time itself. So coming to the discussion, it is basically the cyclodialysis cleft is the separation of the ciliary muscles from the scleral spur, forming a direct connection between the anterior chamber and the suprachoroidal space. And confirmatory is the gonioscopy. If it is not possible to do the gonioscopy, then we can do the UVM anterior segment OCT. And now there are various management strategies for management. What I adopted was the photocoagulation and internal sulcus with haptic of the PMMA lens and CTR. So my case was, I think was SSOT, anterior segment OCT was very much helpful in delineating the extent of the CD along with the gonioscopy, and photocoagulation helped me, and cataract surgery with CTR really helped. So I did not need any cycloplexy treatment for this patient. Thank you.
One of the most difficult cases to manage in glaucoma, I can see decline, very well managed. Any questions from the house or the panel? So, sir, usually, how long do you advise the patients to wait before intervening, before doing anything?
It's always better to intervene before 3 months, because there will be permanent change in the macula. But if you see that the pressure is not rising by any means, then I think considering everything, like patient had cataract also, so you have to manage the cataract also. So in that case, we have to intervene early also. And this patient was non-compliant. He was actually a mazdoor, a laborer in Gujarat. So he was very much कि ये मुझे जाना है जाना करके. That's why I took little early stage also.
You're so famous in Gujarat.
गुजरात नहीं, वो बिहार के सारे उधर ही जाकर काम करते हैं.
So, Dr. Himani, Dr. Himani is going to talk about a very unusual case of disc edema or something else, something unexpected in glaucoma patient. Dr. Rafi is not there, right? So I request Dr. Ipsika to be ready with the presentation.
Very good afternoon, everyone again. I'm here to present a case presentation with the topic of disc edema or something else in a glaucoma patient. So 61-year-old female patient presented with a complaint of redness and watering in both eyes since 3 months. On ocular history, she was using fixed drug combination of anti-glaucoma medications. On examination, her vision was 6/9 and 6/18 part in right and left eye respectively. Her conjunctiva was congested with mild papillae changes, and her lens was cataractous more in left eye as compared to right eye. On 90D, disc appeared small and hyperemic in both eyes. The pressure was 20, as well as the gonioscopy was open in both eyes. So the diagnosis we made is ocular hypertension with allergic conjunctivitis and cataract. So we have stopped all medications of glaucoma, and we have given lubricating olopatadine and loteprednol. On follow-up, when patient was symptomatically better, we have done autoperimetry, OCT, fundus photograph, and pachymetry with complete retinal examination. So on perimetry, the both eyes fields were reliable, and it suggested of diffuse generalized depression more in left eye as compared to right eye. On OCT of circumperipapillary elevated and thick RNFL on the nasal side was seen, which gives similar look like what we see in disc edema, but the fundus photo showed a contrasting picture of intact disc margins. The OCT of GCC was non-significant. Pachymetry was 538 and 527 in right and left eye respectively. So we made 3 differential diagnoses, that it's an either disc edema, thickened RNFL, or peripapillary retinoschisis. So to rule out this, we performed a horizontal linear OCT scans of disc and macula. On horizontal linear scans of discs, we have seen splitting of retinal nerve fiber layers on both the nasal side and both the eyes. And OCT macula have non-significant changes. So we made a diagnosis of ocular hypertension with isolated peripapillary retinoschisis. So what is this? Schisis is a Greek word which means splitting, and when there is an abnormal splitting in the retinal layers, it is termed as retinoschisis. It can occur in peripheral retina, macula, or at peripapillary tissue. So it is associated with X-linked retinoschisis, degenerative myopia, and other congenital optic disc anomalies. It can be located anywhere, but commonly seen in inferior and superior quadrant, and mostly affect the inner retinal layers. So various pathogenesis have been done, like vitreous flows through microhole, along with vitromacular traction and ocular hypertension, or small changes in axial length with fluctuations in IOP, or thinning of optic nerve tissue, which have provide a conduit of fluid entrance in glaucoma patients. So these might be the reason of PPRS. So the risk factors are either high axial IOP, high IOP, high axial length, vitreomacular traction, glaucomatous cupping, optic disc pit, or macular schisis. So the further questions were, is it rare to find in glaucoma? Does it affect the progression? Or is there any immediate intervention needed? So various articles have documented retinoschisis in a variety of glaucoma. Major trials have also been done between its association in glaucoma. And regarding its progression is usually misinterpreted as PPRS is overlapped by retinal nerve fiber layer defect. On the left side, it is a red-free fundus photograph where only RNFLD can be seen, whereas on the right side, it is the infrared fundus photograph where two entities can be differentiated. The orange one is PPRS and the white one surrounding the RNFLD. So once the underlying PPRS is resolved, false thick RNFL is no more and it is present as a defect which happens to be sudden. This sudden defect can mislead as progression and hence glaucoma management. So no immediate intervention is needed, but surgical intervention is needed when IOP is uncontrolled or maculopathy is present. Its natural history is either it won't expand or it will present with a new location or it will resolve either by itself or by reducing high IOP. So the risk factors in our case was high IOP, average axial length of 24.5 and little traction. In our case, the reason of PPRA is probably because of high IOP. So mostly PPRS is overlooked in clinical practice because it is often asymptomatic in patients and on fundus examination is hard to detect. Pathophysiology is not clear and therefore we need to aware of this atypical finding. So retinoschisis is not rare. Its resolution can affect the progression of glaucoma and if any record is present, then investigations before its development and after its resolution can help in assessment of actual progression. These are my references. Thank you everyone. Yeah, it has been reported. Uh, Percentage of PPRS and maculocysis. I don't know about the percentage, but they have reported cases of maculocysis with PPRS. So in our case also probably if we'll follow her up more, then probably we can find maculocysis in like future. Probably, like not sure.
Right, because if you find a case of retinoschisis or macroschisis, so do we really need to look at the peripapillary layer? That's why I asked you the question. And why not?
Okay, yes ma'am, why not? Because if optic disc anomaly is there, we see maculopathy abnormalities. So if only optic disc anomaly is there, then it's like vice versa. We have to rule out both. OCT images. Acha, OCT, okay. Sorry, sir? I think so signal strength is suggestive of reliable OCT. And, yes sir, please go on sir. Signal strength is 8 and 7, sir. Yes, sir. Okay. Okay. Okay, like. Okay. Yeah, yes, sir. Yes, sir. Mm-hmm. Okay, yes, sir.
So Dr. Dixit is going to talk about the case of Sturge-Weber syndrome. Dr. Prasanna, you are next. And Dr. Mazan is here now.
The mouse isn't connected.
Not the mouse, the thing. Laptop mouse.
Point. This cursor needs to be on. There's a progression bar if you can turn that on. Thank you so much. So, after we made a side port, we went ahead and inserted a 7 vicryl suture inside in hope of blocking, in doing an internal tube ligation. So, but then post AC formation, the AC was shallow but formed now. There was no tube cornea touch. Finger tension was still soft. The fundus still showed choroidal detachment. So now we planned on closely observing this child. 3 days after the AC formation, however, the AC was once again flat and there was tube cornea touch. Finger tension was soft. Choroidal detachment still persisted. So now we planned on AC deformation again, but this time with ligation of the tube after opening the conjunctiva and to look for peritubal leak. So once again on table, first we stained with fluorescein dye, but then we didn't see any peritubal leak as such. And later on we made a side port and injected trypan blue dye, but then as you can see, no dye is really entering the AGV tube. So we realized that AGV is not the source of the problem, but it is the choroidals that is causing all the issue. So we started the patient on tab propranolol 15 milligram BD after consulting with the pediatrician. After 4 days, the AC started to deepen. On 3 weeks follow-up, the AGV was in place, no tube cornea touch, AC formed, IOP of 14, and the fundus showed no choroidal detachment. 2 months follow-up, BCV of 636 and 24, AGV in place, AC formed, IOP of 14 and 18, fundus showed advanced cupping but no choroidal detachment. So there's a study by Dr. Shushmita Kaushik on perioperative propranolol being a useful adjunct for glaucoma surgery in Sturge-Weber syndrome. It says oral propranolol seems to be an effective method to minimize the development of sight-threatening choroidal effusion after glaucoma surgery in Sturge-Weber. A dose of 2 milligram per kg body weight is used 1 week before and 6 weeks after the surgery as per this study, and that's what we did. So to conclude, glaucoma associated with Sturge-Weber syndrome is difficult to treat. It's prone for complications like expulsive choroidal hemorrhage and choroidal effusion. Oral propranolol can be used routinely to reduce choroidal effusions. Thank you.
Thank you, Dr. Any questions from the panel?
Why did you not do a preventive?
Mike.
Worked, and after that we have actually done few more without any posterior sclerotomies in Sturge-Weber with just propranolol, which have worked very well from the beginning without any choroidals.
So, Yosita, basically with propranolol, there's no large case series
Large
reported.
scale series.
So we are just taking a risk by avoiding the prophylactic sclerotomy. And till, we are not sure whether, but it is not very easy to manage. So it is a great, nicely managed.
Thank you.
Nicely.
Thank you.
Thank you. Dr. Prasanna, yeah, you're next. He is going to talk about glaucoma drainage implantation in AR syndrome. Last call for Dr. Rakhi, and Dr. Muazzam is there. Okay.
Till Prasanna is loading up, we had a case on angle recession, and which had asked why we should do other eye gonioscopy also. So just for the PGs, you have to understand that sometimes you feel that there is a 360-degree angle recession, widened ciliary body band. But it might not be the case, because if you do the other eye gonioscopy, in some patients, the ciliary body band is very prominent. bilaterally, you have to do the gonioscopy, so you have to know, then only you will get an idea whether this is a pathological one or it is a physiological large ciliary body band or prominent ciliary body band. So that's the reason we should always do gonioscopy in both the eyes. And again, I think one, I don't remember the speaker, there was mentioned about in angle recession glaucoma, a traumatic case, bimatoprost was used. So one of the contraindication for prostaglandin usage is acute inflammation. So whenever you have an acute inflammation, you are not supposed to use prostaglandin analogs or pilocarpine. How long was it? I was busy with the, okay. So by 6 months already fibrosis has occurred at the angles. Then it's okay, but otherwise in acute condition never use pilocarpine and prostaglandin analogs.
Thank you for this opportunity. My case is on a glaucoma drainage implant in a pregnant woman with axon-filled Rieger syndrome. So, 28-year-old pregnant woman, 30 weeks of gestational age, progressive loss of vision, the last 6 months, and the IOP not controlled, and she's not happy. So the history goes back 2014. She's going for a routine checkup. She's diagnosed with axon-filled Rieger syndrome elsewhere without glaucoma, and she has told to come for an annual checkup. And 2014, this was her visual fields, and 14 to 18, she lost follow-up, she developed glaucoma, and the provisional diagnosis was changed to axon-filled Rieger syndrome. She was started on treatment, and then again that she had a superior arcuate scotoma, and then she again lost follow-up. So this is when she came to us. She got pregnant in between. This is a second pregnancy, and the pregnancy actually exaggerated her glaucomatous process in the 6 months from first trimester to third trimester. And the second opinion is when we are seeing the patient first, and the other history was all got from her from the documented case sheet. She's more like an one-eyed. Right eye is the only seeing eye. Left eye, it's a tubular vision, 3/60. And this is the ocular features suggestive of axon-filled Rieger syndrome, and the face shows mild craniofacial dysmorphism, and the examination reveals IOP to be very high, 38 and 32, and also to add on, she's having gestational diabetes mellitus for 7 months. It's a near GOA 0.9 cupping, and this is a right eye. You can see the superior ganglion cell inner plexiform layer alone is preserved. The RNFL is completely lost. In the left eye again, it's complete tubular vision. Only a small temporal crescent is seen. At least the right eye has to be saved. Again, you can see in the right eye only the superior ganglion cell inner plexiform layer is preserved, and the visual field is a 10-2 visual field corresponding to the same, showing the inferior field preserved. The left eye was more or less a complete loss of RNFL and ganglion cell inner plexiform layer. So we re-diagnosed the patient as uncontrolled bilateral advanced glaucoma with axon-filled Rieger syndrome, left eye greater than right eye, despite maximal treatment. We stopped the prostaglandins because he was entering the 30th week in view of contractions, request for obstetrician fitness, and proceeded with the AGV implantation tube, right eye, tube in the sulcus under subtenon's block. We contemplated goniotomy, trabeculotomy, but that's not possible in ARS, and even trabeculectomy with MMC, that's not possible. So why tube was? Because that was the only viable option, because MMC was teratogenic, and there is also a risk of late postoperative endophthalmitis if trabeculectomy is done with MMC. But more or less it's teratogenic to the baby, that's why we didn't go with trab with MMC. We went with this is the patient's right eye and left eye respectively. You can see the videos post-surgery in the right eye and in the left eye. Left eye, the surgery was done after the pregnancy was completed. We did attempt a trabeculectomy in the left eye, but the left eye bleb started to scar. And the right eye, you can see post the AGV sulcus well placed in the Ahmed glaucoma tube is well placed in the sulcus. And the left eye, though we did after the pregnancy was completed, a trabeculectomy, within 1 month the scarring happened. So this is the timeline. She presented with a maximal medical therapy. And then in the right eye, it went into AGV, and the left eye, we did a palliative trab, and 1 year follow-up, and now she's in 18-month follow-up. We did have to start 2 anti-glaucoma medications. Even today, she's on brinzolamide, timolol in the right eye, brinzolamide, timolol, and bimatoprost in the left eye for her IOP to be 13 and 14 respectively. So take-home glaucoma surgery can be performed with caution in second and third trimester if the patient has a strong indication for it, the patient has been follow-up, and if not, there is some recovery of an RNFL, is at least what the Hood's report is showing us in the subsequent follow-up. And gonioscopy, again, it's always very important in axon-filled Rieger syndrome. We did that also. Family examination completes it. She already had a daughter, and now the son who was born as a second child, he had axon-filled Rieger syndrome. We did examine the newborn because it's not over until we examine the children too. And currently he is under follow-up for the corneal diameter and the axial length, and this is his parameters as well. So the salient features, it's a rare case, pregnancy complicated it. Usually pregnancy reduces the IOP, but in this case it was counter versa. Glaucoma was refractory, especially in the pregnancy period. Before that it was very subtle, but during the second trimester and third trimester it was even more. Combination of paradoxical hormone-induced effects, mild metabolic acidosis, we don't really know. The patient has been followed up for 18 months, family screening done. The glaucoma surgery was advised. Ogician and neonatologist was kept on standby. Subtenon's anesthesia was done with fetal monitoring because they had the less systemic absorption than a retrobulbar. Group B drugs can be safely used. We used only lignocaine. We did not use bupivacaine because of the fetal bradycardiac effect that the group C drugs can bring in. General anesthesia was not done again because of the low birth weight and the neural defects. And MMC was contraindicated. We were not able to do a plain trabeculectomy, though the pressure was 38, because of the contraindication of MMC due to teratogenicity. That's why we went for a tube. And to prevent systemic hypotension in the surgery due to aortic and venal cable compression, we made sure we put the patient in the supine position. The hips were turned and rotated towards the left, accomplishing a left down decubitus position while maintaining the head towards the right tilt so that we were able to perform the surgery well. So these are my acknowledgements and my mentors for this case. Thank you.
Just wanted to know how did you manage this? I mean, it's written there, but this to turn the hips and legs to the left side and the head to be straight. Is it easy?
Ma'am, it was not easy, ma'am. Everything about this case was
Because
not
this is
easy,
the
ma'am.
third trimester you were doing the surgery, na?
Yes, ma'am. It was not easy, but
But you managed.
but it had to be. We had multiple opinions taken. It was. I took my opinion from a mentor and as well as.
I'm just asking about the positioning of the patient.
Physicians helped us a lot in that, ma'am. They were there when the surgery was done. Yeah, the fetal monitoring was also set up during. Yes, ma'am. The neonatologists were there, and if any worst case scenario, even a delivery was also planned at the time. The idea was, she was already near blind in the left eye. The right eye was going in for that, so we had no other option after much.
Sir, can you explain?
Left eye, we did the trabeculectomy after the delivery was completed, ma'am.
Can you explain the position 1 second when you were operating?
Sir,
Can you explain the position given to the patient when you were operating?
position?
Position given to the patient when the surgery was being done.
The position of the patient. Sir, the hip and the legs were tilted towards the left, and the upper body was tilted towards the right, so that the head was straight. So that was the left decubitus position, with the hips and the legs tilted towards the left. And
It's a very difficult position for the patient also and for the surgeon also. That's why I asked you to repeat.
yes,
So
sir.
how was it possible? Because it is not easy for the lower half to be twisted to one side and the upper half to be twisted to another.
Sir,
way.
even some amount of microscopic tilting
Yeah.
also was done, sir.
The
That was
the
also
surgeon
done.
also is in an uncomfortable position when you're doing
Yes.
that. So for everybody, it is very important to know which class of drugs can be given in which trimester of pregnancy.
Yes, sir.
So this is a very, very important issue. Now, because this case was an accident, why didn't plan a mixed procedure in this?
Sir, angle is completely deranged for this
So you
patient.
didn't find any areas of open angle?
No, sir. We did try to see whether that was possible. That's why I had put the gonioscopy, sir. It was completely not possible,
You
sir.
couldn't get any clear area
Any
of
clear view.
open angle. That's
Yeah.
why this was planned. Okay.
And
So the-
moreover, the temporal area was completely lost, sir. And again, if you are going in for another quadrant, it was even complicating further the tilting of the patient, the positions, and everything else.
So you should know the class of drugs which you are supposed to give during pregnancy. That is very important. If you haven't access to an SLT machine, you can always go for opt for an SLT to buy some time during the pregnancy if you want to avoid the medicines. And if there is no choice, then you are left with only surgical choice. And again, as he mentioned, no mitomycin during pregnancy and no prostaglandins in the last trimester. This is very, very important for all the postgraduates. You should remember this.
So,
So
and
very nice
we
to know.
didn't, we also avoided bupivacaine, as you rightly
Yeah.
pointed out, sir. We
So the
did only
class
lignocaine
of drug
anesthetic.
is very important, and there has to be a close association between the anesthetist, the ophthalmologist, because usually we are not aware of which class to be used in pregnancy. So
Yes,
it is
sir.
basically the obstetrician will guide us and the anesthetist will guide us.
And one more thing.
Yes, ma'am.
When there are such high peripheral anti-SINIC or iridocorneal adhesions, putting the tube in the anterior chamber sometimes is very difficult, and you have to be really careful
Yes,
unless
ma'am.
the AC is properly right to
Yes,
avoid
ma'am.
touching the cornea.
We are all, sorry I didn't show that, ma'am. The corneal specular also has been monitored for her frequently, and because of the superior area where we had an area of no iris, that particular area, we were able to keep it in the sulcus that way. That was a lucky spot.
After the pregnancy, how the blood behaved? Because of lot of severe positive pressure during the pregnancy. Was this the pregnancy was a normal pregnancy or a LSES?
Sir, this was actually finally an LSES.
Then it was okay. If it was a normal delivery, then there would be a lot of difficulty with the blood survival also.
Everything about this case, we learned a lot, sir. We were not able to take a single way of approach, but then things had to be done the way it was done.
How long has it been now?
And now it's actually 2.5 years follow-up, ma'am. She's doing well. Her first daughter did not have any issues, but the son who was born of this particular pregnancy, he's got caught with the axon-filled riga, but we are following him also once every 3 to 6 months.
So very, very nicely managed, Prasanna.
Thank you, sir. Thank you.
Go ahead with the next case.
So Dr. Muazzam is the next speaker. He's going to talk about the rates of follow-up and glaucoma knowledge in a South Indian population. I request the speakers to stay back. We'll have a group photograph at the end.
Yeah, good afternoon. So my topic of today's presentation is about the compliance and follow-up. So we wanted to see what was the knowledge of glaucoma having in the patient population. This study was done in a South India population. And what was the percentage of follow-up also. So this was a prospective randomized control trial. So these are my financial disclosures. So the purpose of the study was to evaluate the impact of traditional counseling, which every one of us do. And then there was a patient-centric counseling in which a patient was given a separate room with one counselor, and we have some photos also and pictures also to make him or her understand. And then there was along with the patient-centered counseling, there was a third way in which we have given some audio reinforcement also, so as to explain about the disease process and all, and what if she doesn't do the follow-up. So what was the need of this study? See, we have had a lot of previous study which has actually highlighted the role of follow-up. In one of such a study was like follow-up is as important as the drug regimen. So keeping all this in mind, we have designed this study. And to our knowledge, there was no prospective studies been done which has addressed the glaucoma knowledge improvement and the retention of this knowledge to the patient. So with this RCT, we sought to determine the extent of the problem of the follow-up, then to evaluate the knowledge gains through these counseling, and to determine whether new counseling strategies and techniques may improve the longitudinal follow-up of glaucoma patient. So as I said, it was RCT. So we have had 399 patients from Arvind Eye Hospital, Madurai. And these were our inclusion and exclusion criteria. Mostly we have taken the primary glaucoma patient and PX patient. So the study approval was taken from both Arvind Eye Hospital as well as Stanford University Medical Center. And the declaration of Helsinki was taken into account. So all subjects were randomized to one of these three groups, like one is traditional counseling, one is patient-centric counseling, the third one is the patient-centric counseling with audio reinforcement. The demographic and clinical information of each patient was ascertained. So what we did first is all subjects completed the glaucoma knowledge assessment score, that is GCAS, before and after counseling session at the time of diagnosis and at 1 month follow-up period. So it was basically the GCAS was ascertained by giving a simple 8-question format of true and false. Very basic questions. I'll show you in the next slide what are those questions. And then patient were instructed to return to the clinic on follow-up 1, 3, 6, 9 and 12 months after enrollment. So the appropriate statistical tests were done to get our result. So our main outcome measures were glaucoma acknowledgement assessment score, rate of appropriate clinical follow-up. We have defined the appropriate clinical follow-up as 3 out of 5 follow-ups. And there were some factors, if there is any factor which is independently associated with appropriate clinical follow-up. So these were our outcome measures. So we saw that only 13.5% subject had appropriate clinical follow-up. That is, out of 5, they completed at least 3 follow-up. There was no significant difference between all these 3 different counseling techniques. And GCAS, the glaucoma knowledge assessment score, was increased with the counseling, but after 1 month it has come down. So these were the follow-up. So some other factors were like, if the household income was less than 2,500 rupees, the follow-up were less, GCAS score more than 5, and undergoing any ocular surgeries, these patients had better follow-up. So these were our result. So in conclusion, all 3 counseling methods resulted in transient improvement of patient knowledge. Follow-up were bad in all those 3 groups. And there were some limitations also, like the counsel were of the same sets of counselors. So there was some blurring between those 3 techniques. And with this, we also wanted to evaluate some other studies also to assess some novel technique of glaucoma counseling so as to improve the follow-up and to increase the knowledge and to keep that knowledge into memory for glaucoma patient. Thank you.
Was there any family screening done or anything done towards that?
Madam, the proper demographic and family history was taken into account. Yes, ma'am.
Any other questions?
Counseling is very, very important in glaucoma. Not only for the disease knowledge, but also for the medications also.
Yes.
Because a proper counseling only will give you a proper compliance from the patient. If there is no counseling, compliance will be an issue. We have so many glaucoma patients. You also have been in Arvind. I am also dealing in a charitable hospital. So if you have not given enough chair time, whatever medicines you prescribe, only that particular bottle is used by the patient, and then he comes for a follow-up after 3 months, and he'll say that you had only told to use this bottle, so I bought 1 bottle and that's it over. So proper counseling is important for a proper adherence, and counseling with the family members help us in creating awareness so that we can get other glaucoma patients, other patients who will come for glaucoma screening. The immediate family members plus the extended family. So counseling should be done with the patient and his family members in total. Very nice study, bro.
Thank you.
So very nice presentations we had in this session, except for one dropout, variety of different cases, good knowledge sharing. So with this, we come to the end of the session. I thank the moderator, Dr. Richa, chairperson, Dr. Manoj, Dr. Swati, and everybody who is there, Dr. Divya. So we conclude this session. I request all the speakers and the chairpersons to come for a group photograph. We still have 5 minutes to hand over the hall. So we were on time because of one dropout. We were able to finish 5 minutes early. Thank you.